Is it audible nicely, na? I'm not using the earphones.
Hi, everyone. Very good afternoon.
Hello, students. Good afternoon, all. Good afternoon, ma'am.
Hi, Dr. Vedi. Good afternoon. Am I visible? Okay. So welcome all to another scintillating, amazing integrated session brought to you by Nextillo. I think this is an amazing idea where we are integrating different subjects so that our students can get a very holistic view of the entire topic, and not just like subjects, not just like pathology or anatomy or physiology or gynecology or medicine part of it. It is a very integrated approach, and I think this is a brilliant idea. All thanks to Dr. Sunil, who has brought this amazing platform to us. So today there is an integrated series on pathology, on tumors of the ovary, and we have gynecology and pathology integrated today. So I'd like to invite Dr. Vedi to start this topic, and then I'll join in between to explain about the pathology. So over to you, Dr. Vedi.
Sure. Okay, firstly, I would like to thank Dr. Sunil sir for making this platform and initiating such a series where we can integrate two different subjects, and this actually helps students to better correlate with different topics. So this was when it came to combining gynec with patho. I think ovarian tumors was the first topic which came to both me and Shruti ma'am's mind. So here, this is an attempt where we both will try to simplify and make you guys be able to understand that what exactly the ovarian tumors are, helping you in the histopathological as well as the clinical correlation and how to manage it. Okay, so let's begin with today's session. So firstly, that's an integrated lecture on ovarian tumors. So basically, if we talk about ovarian tumors, these are the tumors which occur in ovary, and broadly you can classify them into 4 different categories. So it could be either a functional ovarian cyst, or it could be a benign tumor, it could be some certain kind of borderline tumor or malignant tumor. Now, if you talk about these tumors of the ovaries, so most of the times they are going to be asymptomatic, and the patient is getting diagnosed on an incidental finding on ultrasound. So how are you going to proceed further? So let's begin with the first classification, that is the functional ovarian cyst. So these are the functional. So as the name suggests, that's the functional. So there is some abnormality in the function of the ovary which causes the formation of cyst, and these present to us with the mass. So these are temporary disturbances in the hormone which occurs, which leads to the formation of a cystic structure in the ovary, and they are going to regress spontaneously. Okay, so of them, one category is the follicular cyst. So most common functional tumor is going to be the follicular cyst, and normally what happens during each menstrual cycle, the follicle is going to rupture, but instead of that, instead of undergoing apoptosis, it does not regress and it continues to grow further, and this is going to be more than 3 centimeter in size. Okay, so that forms the functional follicular cyst. Next we have is the corpus luteum cyst, wherein the functional non-neoplastic enlargement of the ovary takes place, which is because of the overactivity of the corpus luteum, and it is this corpus luteum, as we all know, is responsible for secretion of the progesterone. So that is going to form the corpus luteum cyst. Now, if we talk about certain small one-liners, the most common cyst to rupture is going to be the corpus luteum cyst. And if we talk about complications which are taking place inside such kind of any functional cyst of the ovary, then most commonly what we see is it can undergo torsion. It can lead to rupture of the cyst, which is again most commonly seen with the corpus luteum cyst. Then hemorrhage, which can take place in such kind of cyst, might be infected. It can also lead to the pseudomyxoma peritoniae, which is most commonly seen with the mucinous cyst adenoma. And lastly, malignant changes can take place. Next, we have the benign ovarian tumors. Okay, so that is one category. Smriti ma'am will be describing in detail about this topic. What are you, Smriti ma'am?
Okay, so we'll start with benign ovarian tumors. I'd like to share screen. All right. So we'll start with the WHO classification. Now, as Dr. Vedi already mentioned, we have benign and then borderline and malignant tumors. So in the broad categories, if we categorize the ovarian tumors, it can arise from any part of the ovary. So if it arises from the epithelium or the lining surface of the ovary, they fall under the surface epithelial tumors, which form a majority chunk of the ovarian tumors, about 90%. Then there are germ cell tumors, which arise from the germ cell layer of the follicles. And then there are sex cord stromal tumors, which arise from the stromal areas of the ovary. And then last are metastatic tumors, which can arise from any of the other organs and have metastasized to the ovary, right? Okay, so now we come to the classification. As I already told, they can arise from any of the parts of the ovary. Starting with surface epithelial tumors, as the name suggests, they arise from the epithelium or the lining of the ovary. Now, depending on how they behave in the microscopy, they are divided into these categories like serous, mucinous, clear cell, endometrioid, and Brenner's. We'll come to the details of these soon. This picture just gives a very broad idea of the classification based on the cell of origin. So as I already told, the epithelial cells form 90% or the chunk of the ovarian tumors. And after that, we have the sex cord stromal germ cell, and then there can be a mixed type of tumor. Again, a picture which is telling us from where which kind of tumor arises. So the first are the epithelial cells. The first are the epithelial cells which arise from the epithelium of the ovary. Then there are the germ cells, the germ cell tumors, which will arise from the lining of these germ cell follicles. Then there can be the sex cord stromal tumors, which arise from the sex cord cells. Okay. So as I already told, which all tumors come under the surface epithelial tumors. These are a list of tumors which are under the germ cell tumors. That is the dysgerminoma, choriocarcinoma, teratoma, embryonal carcinoma, and yolk sac tumor. And then the sex cord tumors, they are the granulosa cell tumors, the Leydig cell tumors, fibroma and fibrothecoma. So now we start with the surface epithelial cell tumors. Over here, I would like to emphasize that the WHO classification has been recently revised in 2020. And there are a little differences from how these tumors were classified earlier. Why you need to know this is because this is a very recent classification and very likely to be asked in your examination. There are not a lot of differences. The only major difference that you need to know over here is that in surface epithelial tumors, when we talk about the serous tumors, they were earlier all thought to be arising from the ovarian epithelial cells, while in the latest classification, we now know that the malignant or the high-grade kind of epithelial tumors do not arise from the ovarian epithelium. They instead arise from the fimbriated end of the fallopian tube. And these cells from the fimbriated end of the fallopian tubes go and enter the ovary and form a cyst over there. And then the high-grade ones are basically arising from these intratubular epithelial carcinomas. We'll come to it. Okay, so this is the major difference that you need to remember. Now, surface epithelial tumors arise from either the fallopian tube or cysts on the ovarian cortex. So that is why I am emphasizing here that not just from the ovarian epithelium, these surface epithelial tumors can also arise from the fallopian tube. Now, if they are benign and cystic, they are called cyst adenomas. Okay, cyst adenomas. If the cyst also has some kind of a stromal component, the stromal component we generally know is a very fibrous kind of a component. So they will be called as cyst adenofibromas. You just have to break down the words to understand what these tumors are. And then you'll be able to identify the histopathology or the microscopy of it. Now, if there is a malignant component along with the cystic component, instead of cyst adenoma, these will be called as cyst adenocarcinomas. And if it is just a malignant solid tumor and there is no cystic component to it, it will be a carcinoma. Now, they can be benign, borderline, or malignant. The borderline category is an intermediate category between benign and malignant, and they generally behave as benign tumors only, but they may recur after being removed, and then they may progress to a carcinoma. So now we'll start with serous epithelial tumors. So inside the surface epithelial tumors, we saw a variety of categories. The first one in that is a serous epithelial tumor. Why is it called serous? Because the fluid that is being secreted is serous type of fluid. It is a very thin, watery kind of fluid. These are the most common kind of epithelial ovarian tumors, and they form the greatest fraction of malignant tumors of the ovary. Now, these serous tumors may be low grade or high grade. Now, low grade carcinomas arise from either benign or borderline lesions in a stepwise fashion. What does it mean? That first, a small benign lesion may be there, then it may progress to a kind of borderline lesion which has slight atypia but is not frankly malignant, and then it will go on to become malignant. But these malignancies are again very low grade malignancies. You need to remember over here that these kind of tumors or low grade tumors are associated with KRAS mutations. This is something which is very commonly asked in your questions, and this is also associated to that WHO classification that we recently talked about. So KRAS mutations generally seen in these low grade carcinomas. Now, if we come to high grade carcinomas, they develop rapidly and they do not arise within the ovary itself. They arise in the fimbriated end of the fallopian tube via serous tubal intraepithelial carcinoma. So there is a preceding stage to these tumors, which is called as serous tubal intraepithelial carcinoma. And then it rapidly kind of develops into a high-grade carcinoma. And these kind of tumors, these kind of serous epithelial tumors are associated with a TP53 mutation. So these are the points that you need to remember. This is just a picture which is showing you the difference between the high grade kind of a tumor and a low grade tumor. So the type 1 or low grade arises generally from the ovary itself, whereas the high grade one or the type 2 will arise from the fallopian tube in the form of a serous intraepithelial carcinoma and then rapidly develops into a high grade ovarian carcinoma. So now coming to the morphology, how they look on gross. They are basically spherical to ovoid structures. They look very cystic. You know that they are kind of filled with a fluid on gross examination. And they have a smooth surface if they are benign. If they are towards malignancy, they'll kind of have an irregular surface. They can be unilocular. That means when you cut it, there is only a single cystic cavity, or they may be multilocular. That means when you cut it, there are multiple cavities inside, and these are filled with a serous fluid. That means very thin, watery kind of fluid. On microscopy, the benign ones would be just lined by a single layer of very uniform looking cells, uniform looking columnar epithelial cells, which may be ciliated at times, and there is presence of psammoma bodies. So in the exam, if they give you a picture of an ovarian tumor, histopathological picture, and you see those small calcified areas which look very dark pink in color, with the world appearance, then you know that this is kind of a serous tumor. Now, if they are malignant, instead of a single layer, there'll be multiple layers. There'll be a lot of architectural complexity that you find there. There can be a lot of papillary projections, or there can be nests and sheets of these malignant cells, and they may be found to be invading the ovarian stroma as well. So this is a picture which is kind of telling you the differences between the benign and borderline and malignant kind of tumors. The first one, picture A, just has a very thin lining of uniform appearing cells. So this is a benign cystic lesion, whereas the second picture, you can see a little bit of complexity over there, but they do not look frankly malignant. Their cells are not looking very atypical. They do have a little bit of papillary projections, and a little bit of complexity is present. So these fall under the borderline category. The third one is showing you papillary projections. So there is a complex micropapillary kind of arrangement. And the fourth one is the frankly malignant or the high-grade serous carcinoma, where you can see that there is underlying, it is invading the underlying stroma as well. And there are very complex architectural features you see in this picture. After serous, we come to mucinous epithelial tumors. So the only difference over here is that instead of secreting a very thin serous kind of a fluid, these are filled with thick mucinous fluid because their epithelium is mucin secreting cells. Only 10% of these are malignant, and they may seed the peritoneum. So these tumor cells may go out and seed into the peritoneal cavity. And over there, they may form a very mucinous kind of ascites, so which is called as a pseudomyxoma peritoni. These kind of tumors are again associated with KRAS mutations, and they have a better prognosis than their serous counterparts. This is a picture of the mucinous kind of tumors. So as compared to serous ones, they are generally multilocular. Over here, you can see that there are multiple small cystic spaces. So they are multilocular, and these are filled with a very mucinous kind of a fluid. And if you see the microscopy, they're lined with these tall columnar mucin secreting cells. Now we come to the other type of surface epithelial tumors. So what is an endometrioid tumors? Yoid generally means looking like, right? In pathology, you need to know the meaning of the words. And if you know the meaning of the words, you just arrive to the, diagnosis yourself. So what does an endometrioid means? That they look like endometrium. Like epithelioid means looking like epithelium. So same way, endometrioid means looking like endometrium. So endometrioid tumors resemble the endometrium. They may be benign or malignant, just like endometrial glands. These tumors look like those glandular cells, and whether benign or malignant, they can be benign endometrioid or malignant, and they are associated with P10 mutations. Now, the third one is clear cell tumor. So clear cell tumors basically have large epithelial cells with abundant clear cytoplasm, just like the name suggests. Now, these tumors are PAS positive because of the clarity or the clear cytoplasm. They are PAS positive, and they may be associated with that diethyl stilbestrol exposure. So if in the history they give you kind of a scenario that this patient was exposed to diethyl stilbestrol, so what kind of a tumor it can be? So your first thing that should come to your mind is a clear cell kind of a tumor. Then coming to Brenner's tumors. Brenner's tumors are also called as transitional kind of tumors. These are composed of neoplastic cells or neoplastic epithelium, which resemble the urothelium, the cells that are lining our urinary bladder. So if you remember the histology of your urinary bladder, there are basal cells, which are kind of tall columnar, and they are basically multi-layered epithelium. And when you go upwards towards the surface, there is flattening of these cells, the transitional kind of epithelium. So similar epithelium we find, similar nests of cells we find in the ovary in a Brenner's tumor. And these nests are surrounded by dense fibrous stroma, and their nuclei have a slight grooving, which gives it the name of a coffee bean nuclei. So coming to a picture of a Brenner's tumor, as I said, there are nests of transitional epithelium. There are layers of these cells which look very much like the, the epithelium of your urinary bladder. And they're surrounded by this dense fibrous stroma. Okay, so now this picture just gives you a very brief description of how the other kind of ovarian tumors would look like. So we come to a dysgerminoma. So a dysgerminoma basically is generally seen in the 2nd to 3rd decade of life, and they are the counterparts of testicular seminomas, very similar morphology to what you see in a seminoma in the testes. And all of them are malignant, but only 1/3 would metastasize, and they are very radiosensitive. So this is what a dysgerminoma would look like. They are basically nests of cells. Tumor cells are in lobules or nests, and between them are these fibrous septa with lymphocytic infiltration, very similar to a testicular seminoma. This is how it looks under the microscope. So there are nests of these ovarian cells, and then there are fibrous septa in between, in which you can see those small lymphocytes. Now, what you need to remember is that they are radiosensitive, number one. Number two, that they are associated with Turner's syndrome. So if in the history they mention Turner syndrome somewhere, you need to think of a dysgerminoma. And you need to remember the tumor markers. So what are the tumor markers? The tumor markers are PLAP, OCT3, NanoG, and HCG. These are all positive, while they are AFP negative. So this is what you need to remember, that alpha-fetoprotein is negative in a dysgerminoma. We come to a yolk sac tumor. Now, basically, these yolk sac tumor arises from the yolk sac cells. This is the most common type of malignant tumor in a children. And over here, the classic microscopic picture is that in center, you have a blood vessel. If you can appreciate it over here, inside, you can see the RBCs. So this is a blood vessel, and these are lined by these tumor cells. So this entire structure is called a Schiller dual body, and this is the characteristic feature of a yolk sac tumor, which you need to recognize in the microscopic picture. Now we come to teratoma, a very commonly asked question. And you need to know that first thing that you need to know is that these are more common in children. So they are more common in the first 2 decades of life. And the younger the child, the more the chance of this tumor being malignant. Now, these arise from all 3 germ layers. So the constituents can be arising from the ectoderm, endoderm, or mesoderm. Now, they can be benign, malignant, or they can have a specialized kind of tissue. What does it mean? We come to it. Now, what is a benign teratoma? It is generally a mature teratoma. That means that the contents of this tumor are mature tissue, like hair or cartilage or sebaceous glands. And most commonly, they're lined by epithelium or epidermis, the skin kind of epidermis. And that is why they're also called as dermoid cyst. Okay, now this skin component can rarely also progress to a squamous cell carcinoma. These are seen in reproductive age group, as we already know. So this is a picture of a gross picture of these mature cystic teratomas. So this is the entire ovarian tumor, and you can see a ball of hair inside in the first picture. And in the second, you can see a proper developed tooth as well as a lot of hair. So this is what we mean by a mature teratoma. If you see maturely formed elements in this kind of an ovarian tumor, it is a benign tumor and it is a mature teratoma. Now coming to an immature teratoma. Immature teratoma are found even earlier in life, and the mean age is about 18 years. They are bulky, and there are areas of cystic change and necrosis that can be seen, and which are again necrosis is again a marker of malignancy. And on microscopy, you will find immature kind of elements, or very minimally differentiated kind of elements, and not completely differentiated proper structures that we just saw. The third kind of a teratoma is a specialized teratoma. Now, what is a specialized teratoma? That means that the entire tumor is formed of one kind of specialized tissue. For example, if it is formed entirely of a thyroid kind of a tissue or thyroid a structure, then it is called as a struma ovari. And these tumors not just look like the thyroid structure, they also secrete all kind of thyroid hormones. And therefore, in such a patient, they may also produce hyperthyroidism. Okay, just a second. The screen is not changing.
Yes, I would like to share my screen.
Yeah.
Yes. So as ma'am mentioned that there is basically the dermoid cyst is going to have a lot of components. It is going to have components of the endoderm as well as different components. So that can be noted on the ultrasound as well as the radiographic features on X-ray. So if we take the pelvic X-ray, then it is going to show the calcification because it could be present because of the tooth or a bone component. Okay. Also, it can show a raised area, which is going to be called as the Rokitansky protuberance, and the similar structure on ultrasound. Now, as ma'am rightly mentioned, that it might be containing a ball of hair, as you can see in this picture. So that on the ultrasound is going to be noted as a mixture of the sebum and the hair, where because of the room temperature, the sebum is going to get liquefied, and the hair is going to float into this particular liquid sebum, which it is going to produce a dash and dot kind of a pattern. So as you can see that this in the picture, you will be able to appreciate the dash and dot kind of appearance. Along with that, there is a hyper-echogenic Rokitansky nodule, where this is the portion of the hyper-echogenic Rokitansky nodule. And if you go for the color Doppler, then there is no internal vascularity, which is noted in this kind of a tumor. Again, this is again a second picture showing the similar of the dermoid cyst. Now, ma'am will carry forward with the choriocarcinoma.
Yeah, hi. I think there was some problem in my screen sharing. So, Dr. Vedi, can I request you to please help me with, yeah.
No worries. Okay, just, yeah.
Okay, so we
one second, I'll go to that side. Yes.
Okay, so we come to the choriocarcinoma now. Choriocarcinoma generally occurs in the elderly, and just like other kinds of choriocarcinomas which form in the uterus, because this is a placental kind of a tumor, they also secrete HCG. So these are HCG positive. Now these metastasize very widely, and we see cannonball kind of metastasis in the lungs. That is, they form huge opacities in the lung, which we can recognize on radiography. And they're very resistant to chemotherapy. Next slide, please. Now we come to sex cord stromal tumors. The first one is a granulosa cell tumor. Now, if you know how an ovarian follicle progresses during general physiology, you would know that they are lined by granulosa kind of cells. Now, and these are the cells which secrete estrogen during this menstrual phase after when these follicles are maturing. Now, these granulosa cell tumors, that is why when these granulosa cells become neoplastic, they would again secrete large amounts of estrogen. So granulosa cell tumors, the granulosa elements, they recapitulate similar ovarian follicular structures. So if you see the picture, there's a circle, you'll be able to see that they form, they look very similar to what a normal ovarian follicle would look like. These kind of structures, these flower-like arrangements, are called as Karl-Exner bodies. So if you recognize these structures in the picture, in the microscopy, you can diagnose that it is a granulosa kind of a tumor. Also, if you focus on the granulosa cells, you'll see that the nuclei have slight grooving in between, and that is why these are called as coffee bean nuclei. The marker that we use over here is inhibin, because inhibin is already secreted by granulosa cells. So when they become neoplastic, they secrete large amounts of inhibin as well, and that is why they can be used as a tumor marker for granulosa cell tumors. Next slide. Thank you. Leydig cell tumors. Now, Leydig cell tumors, as opposed to granulosa cell tumors, these are androgen secreting tumors. So because they are androgen secreting tumors, they cause masculinization. And in microscopy, if you see those small pink structures, they are called as Rehnke's crystals. So these are the specific thing that you have to recognize to identify that these are Leydig kind of cells. So that is how you'll know that this is a Leydig cell tumor. Okay. We come to fibroma and thichoma. So as the name suggests, fibromas are formed of well-differentiated fibroblasts, and they are associated with a particular kind of a syndrome called as Mig syndrome. Now, what is a Mig syndrome? So if in the history they give you, the symptoms of an ovarian tumor, and while the patient also has some kind of ascites, And you can see hydrothorax on the chest X-ray, right-sided hydrothorax. Your mind should go towards Mig syndrome, and that is why where you can get an idea that probably this is a fibroma, because a fibroma is what is generally associated with this kind of a presentation. Then we come to a thecoma. What is a thecoma? They are also spindle cells, but as opposed to normal looking fibroblasts, these have clear droplets inside them, which are lipid droplets. And as we know that oil red O is what stains the fat or lipids. So these kind of tumors are oil red O positive. Okay. So over to you, Dr. Vedi. Dr. Vedi will take over from here for further explanation.
Yes. So, ma'am talked about what the benign tumors are. Now, between the benign tumors and the malignant tumors, there is another group of tumors which is going to be called as the borderline tumors. Okay. So, what is the problem here is that they are not sufficiently malignant enough to be called as malignant, and they are not sufficiently benign to be categorized into the benign category. So, in between these two, what we have is the borderline category. So, here they are going to be a low malignant potential tumors, which is seen commonly in the age group of 30 to 50 years of age, and they are going to have certain malignant characteristics such as the nuclear atypia is going to be present, as well as the mitosis is going to be less than 4/10 high power field, and the epithelial hyperplasia is also going to be present. Okay, but the characteristic which distinguishes it from a malignant tumor is that it does not show the stromal invasion, which is very much required for any tumor to be a malignant variety. 10% of the epithelial tumors are going to be borderline, but of 30%, they are going to be the mucinous variety. The tumors remain confined to the ovary for very long period of time because they are not going to invade the stromal invasion, and they are going to be slowly growing tumors, and they have a relatively good prognosis. 40% of the serous borderline tumors may show and spread beyond the ovary, and here the management is now going to be conservative surgery, where you just go for the unilateral salpingo-oophorectomy, which means on the same side where you have the lesion, you are going to remove the fallopian tube as well as the ovary. As ma'am said already, that recently the culprit for the development of the ovarian carcinoma is from the fallopian fimbrial end. So that is why you also have to remove the fallopian tube. That is, salpingo-oophorectomy needs to be done. Next, we talk about the malignant ovarian tumors, which is also going to show the stromal invasion and the metastasis to different organs. Now, we know if we talk about what the etiology is behind development of this, is the excessive exposure of the estrogen inside the body or the innocent estrogen. So, of these, what happens is there are certain factors in a patient which is going to make herself responsible for the excess amount of the estrogen in her body, namely if there is presence of the nulliparity or there is obesity. So how obesity is going to cause excess amount of estrogen is because of the peripheral aromatization which is taking place due to the this adipose tissue which is present in these obese ladies. Then the development of early menarche or late menopause, wherein the female is going to be exposed to the large number of the ovarian cycles inside during her lifetime. Next is the dysgenic gonads. Next, if you are going to give the clomiphene citrate or ovulation inducing drug, where you are iatrogenically giving the exposure to the clomiphene citrate, which causes excess amount of the follicle formation. So more the number of follicle formation takes place, these follicles would be in turn secreting more amount of the estrogen, and ultimately more amount of estrogen is present in these patients. Then infertility and PCOS. Again, PCOS, there is high level of the estriol in these kind of patients. And lastly, we have the hormone replacement therapy, which is given externally. So these are the factors which are going to predispose to the development of the ovarian carcinoma. Next, there are certain protective factors such as multiparity or the physiological factors like pregnancy or exercise, smoking, and ovulation, oral contraceptives. Now, you must be wondering that oral contraceptives is going to contain estrogen, but the amount of estrogen which is present in this kind of oral contraceptive pills is in very low quantity, particularly if we are using the very low dose or the low dose oral contraceptives. Next, you have tubal ligation, and the hysterectomy is also going to be protective. Lastly, we have the breastfeeding. Now, there are certain hereditary factors which are also responsible for development of the ovarian cancers. Of them, we have connection between the breast cancers and the ovarian cancers. So there are the mutations in the BRCA1 as well as the BRCA2 gene, which is responsible for the development of the ovarian cancer. The BRCA1 gene, we all know, is located on chromosome number 70, and the BRCA2 gene is located on the chromosome number 13. Any kind of mutation in these two genes, it leads to formation of the abnormal BRCA proteins, and ultimately it predisposes to development of the ovarian tumor. Now, comparing between BRCA1 and BRCA2, BRCA1 is going to be both of these are going to be autosomal dominant pattern of inheritance, and the BRCA2 gene mutation, they have a lifetime risk of the breast cancer associated with the ovarian cancer of as high as 82%. Okay, now if you talk about the risk of ovarian cancer in such patients, we have 54% risk which is associated with the BRCA1 mutation, and we have 23% mutation which is associated with the BRCA2 mutation. Next, if we talk about the abnormalities in the genes, the next is the HNPCC gene abnormality, which is going to have the lifetime risk of the 15% chances of ovarian cancer. Okay, and lastly, BRCA1 is going to be more carcinogenic compared to the BRCA2. Next, we have how are you going to counsel such a patient, because she's already at risk of development of the ovarian cancer. So what you need to go is the genetic counseling needs to be done in such kind of patients. And if the patient wants to preserve her uterus and ovaries, what you need to do is that every month, 6 monthly, you need to go for surveillance with the transvaginal ultrasound. Oral contraceptives can be given to such a patient, and the funda behind giving oral contraceptives is you are going to inhibit the ovulation in such kind of patient, and as a result of which the ovulation is inhibited and the risk of development of the ovarian cancer is also reduced. Simultaneously, what happens is you should also counsel the patient that if she is going to preserve the uterus as well as ovary, there are future chances of development. So once the family is completed, she can again go for the terminal treatment. So what is the terminal treatment? That is, if the family is completed or she does not want to have children, what happens? She can go for the bilateral. This is going to be prophylactic bilateral salpingo-oophorectomy after the age of 35 years, but definitely not beyond 40 years of age. If the woman has strong family history of the breast or the ovarian cancer, then again, along with the ovarian cancer screening with the transvaginal ultrasound, she also has to go for the annual breast screening that should begin by the age of 30 years using MRI or mammogram or the ultrasound. And in case of the HNPCC, along not only it is going to be at risk of development of the ovarian cancer, but also these patients are at the risk of development of the uterine cancer. And therefore, along with the prophylactic bilateral salpingo-oophorectomy, what you need to add is the hysterectomy, that is removal of the both ovaries, both fallopian tube and the uterus. That is to be done. Now, if you talk about the malignant epithelial tumor, they are associated with the other mutations such as the P53 or the KRAS gene mutation. And most commonly, what is seen is the P53 gene mutation. Now we talk about the epithelial ovarian tumor. So ma'am already described about how the histopathological variety is seen in such kind of epithelial ovarian tumor. So we have 5 different kinds of tumors. So here, how are these going to present to us, how they are going to spread inside the body, and how you are going to manage it, that will be described in this section. So firstly, if we talk about the epithelial ovarian tumor, how is it supposed to, how it acts inside the body or it spreads? So there are various routes wherein how it is going to spread. Firstly, we talk about would be the transcoelomic spread. The other one is going to be the lymphatic spread. Next is the direct spread into the adjacent tissues. And lastly, we have via blood. So if we talk about the transcoelomic spread, which means what the spread of the tumor takes place via the coelomic cavity, that is exfoliation of the tumor malignant cell takes place inside the peritoneal or the coelomic cavity, and this is going to be the most common route of the spread. So here the cells are going to get released inside the peritoneal cavity, and they are going to go and implant into the adjacent structures inside the peritoneal cavity, such as what is existing surrounding it would be the omentum or even the surface of the intestine, and it leads to the formation of the where these implants would be seeding. They lead to development of the tumors on those particular areas, and it leads to formation of the omental caking, so which is more commonly seen. That is the most common site would be the omental caking. Next, you have the lymphatic spread, which is taking place. This is going to be the next important spread. Now, we all know that the ovary is drained by ovarian vessels, which go and directly drain into the aorta. So, these lymphatic channels are also going to follow the ovarian blood supply, which is going to drain into the this goes along the infundibulopelvic ligament, and it will go and drain into the para-aortic lymph nodes. Okay, from these para-aortic lymph node, what happens is there is a via thoracic duct. What happens? The lymphatics is going to go and drain into the left supraclavicular lymph node, and if these are affected, they are going to be called as the virtuous lymph node. Lastly, pelvic lymph node might also be affected, which includes the external ilia group of lymph node, internal ilia group of lymph node, and the obturator, which is may be seen in 30% of the cases. Next, we have is the direct spread, which is seen, which is the progressive enlargement of the tumor takes place. Then it is going to go and affect the adjacent structures, wherein inside the pelvis we have the uterus, the ureter, as well as urinary bladder, rectum. So all these structures which are present inside the pelvis, they can get affected because of the direct spread. Lastly, we have the hematogenous route of spread. This is going to be the least common mode of the spread, wherein the liver and the lung parenchyma or rarely the CNS can also get involved. Now, how is this patient who is having any kind of malignancy going to come and present to us? So firstly, most of this times it is going to be the asymptomatic. That is, patient comes to us in the most terminal stage, and patient might not be having any kind of complaint. Or if at all there is development of complaint, then it would be extremely vague complaint, just as the gastrointestinal symptoms like nausea, vomiting, dyspepsia, constipation, for which patient might have taken treatment with any kind of the gastroenterologist or routine. But the patient comes to a gynecologist for these particular complaint at a very late stage. Next, the patient might also have abdominal distension or bloating, and this may be because of either the rapid enlargement of the tumor, which is seen in the mucinous cyst adenoma, carcinoma, or it could be because of the development of the ascites. And sometimes the patient also presents with the tense ascites. Because of the compression of the tumor to the urinary bladder, the patient might even have the anuria or difficulty in micturition, or maybe decreased. Patient might have difficulty in passage of urine or urinary retention. Lastly, abnormal uterine bleeding. This is going to be rarely seen with the epithelial tumors, which is more commonly seen with the sex cord tumors. Then patient might also, because of the rapidly developing ascites or compression of the tumor on the diaphragm, patient might also have complaint of difficulty in breathing or dyspnea. And lastly, there would be general symptoms which patient might have, like weight loss, anorexia, vomiting, or cachexia, or feeling of generalized unwellness. And maybe into terminal stages, patient presents to the doctor with the complaint of the cough, dyspnea, hemoptysis, or even neurological symptoms because of the meds. So that was about how the patient is going to present to us. Now, once your patient comes to us, if you go for general physical examination, what you will be noting is the unilateral, or firstly, you need to note for the general appearance of the patient, like patient would be cachexic, or there would be development of the edema, which would be present because of the pressure effect of the tumor on the lower vessels. Then patient might also have lymphadenopathy. Particularly, you need to note for the left supraclavicular lymph node, which is going to be the virtuous lymph node, or even sometimes the inguinal lymph nodes are going to get affected. Then pleural effusion might be noted, which could be noted on the respiratory system examination, where unilateral right-sided pleural effusion is noted. And sometimes coexisting or the mats of the breast mass could be present. It could either be the primary breast tumor with the secondary ovarian tumor affected, or it could be a different tumor. So that needs to be assessed. Now, if you go for systemic examination, in case of abdominal examination, what you need to note is the mass in the pelvis or the abdomen, the bilateral tumor with the vague borders, which is having ill-defined margins, you need to note for the mobility of such a tumor. Now, most of the times the malignant tumor is going to have restricted mobility, or it is going to be a fixed variety. Then ascites is to be noted, which is in the advanced cases, it is seen as high as 75% of the cases, which is the most common sign of the ovarian cancer. And sometimes rapidly developing ascites can lead to the tense ascites as well. Hepatomegaly should also be ruled out, and multiple nodules in the abdomen or the pelvis must be noted. And this is particularly to check the affection of the lymph nodes. Next, you go for the bimanual examination, where you note the cervix, uterus, and the adnexus. So, cervix, uterus would usually be normal. The uterus, the size, shape, as well as consistency must be noted, and it usually feels separate from the tumors because this uterus will not be in direct continuation with the mass. The mass is going to be arising from the ovary, and as a result of which, it is felt separate from that of the ovarian mass. Now, if you're going to go for examining the bilateral or unilateral hard fixed mass would be noted in the adnexus, either of the adnexus. Most of the times these malignant tumors are bilateral, and as a result, you need to note in both the adnexus. And lastly, you need to go for assessing the pouch of Douglas, where you can also appreciate the hard nodules because of the secondary deposit. So these findings are to be confirmed by the per rectal examination. Now, once that is done, the patient comes to us with complaint, you go for assessing all those things. Now, what you need to do is you need to how are you going to manage such a condition? So firstly, you go for, on the basis of the history, the clinical examination, the next step would be you go for investigation, and there are various modalities. One would be the serum tumor markers. The second is you go for imaging modalities. And lastly, what is very important in case of such gynecological cases would be the cytopathology. Now, any kind of the ovarian tumor, the classification or staging is incomplete without the cytopathological examination. So I'll be describing that in later. So firstly, beginning with the investigation. So what you are going to go, you are going to send the investigations of the blood like CBC, RFT, LFT, that is the renal function test, liver function test, electrolyte level, blood sugar level, and the urine routine micro. Next, again, you are going to go for the chest X-ray for such a patient. Not only that helps in the and ruling out the mets in the chest, as well as it will be for the pre-op fitness in the next. Along with that, you need to go for the electrocardiogram, intravenous pyelogram to assess how much amount of the kidney is affected. Is there development of any pelvic dilatation in the kidney or not? Next, you also need to go for the pap smear examination. This helps in ruling out the coexistent cervical carcinoma. But you need to understand here that pap smear is not at all associated, or it does not help in ruling out the ovarian cancer. It is only for picking up the coexistent cervical carcinoma. Next, you go for endometrial sampling. So this is going to be needed for excluding the endometrial papillary carcinoma, which may metastasize to the ovary to produce the secondaries. Now, once that is done, so though that was about the blood investigation which we sent, now we talk about the ultrasound features. Now, see, if you send a patient a patient comes to us with certain kind of mass or any kind of ascites, and you send her to the ultrasound. So there are certain features on ultrasound which help you differentiate that this particular tumor which is arising from the adnexa is actually malignant rather than it is a benign. So there are certain characteristics which help in pointing that this tumor is going to be there are more chances that this tumor is going to be malignant compared to that to the benign. So firstly, to begin with, now we begin with the transabdominal ultrasound, and for the better resolution, what you need to go is you need to go for the transvaginal ultrasound. Okay, so both of these, transabdominal, that is the initial step, which is followed by the next, which is the transvaginal ultrasound. So this not only going to help us in confirmation of diagnosis, but it also helps in assessing the certain simultaneous structures, which would be either you assess the presence of the ascites, you assess what all other structures in the abdomen are affected. Along with that, you check the status of the liver, whether any kind of hepatomegaly is noted or not, as well as you can go for assessing the para-aortic lymph nodes and the renal hydronephrosis, whether the anuria or the kidney is affected or not. Okay, now if talking about the tumors, what you need to see is that the chances of malignancy would be high if on ultrasound, you see bilateral cyst, or with the cyst, there are large number of loculi which are present, or in between the loculi, the thickness would be more than the 3 mm, or the cyst wall is going to be more than 3 mm thick, or if there is the combination of a solid mass along with that of the cystic mass. So if there is partial solid as well as partial cystic component, there is a high chance that this is going to be a complex cyst, which is a higher malignancy chances. Then since any tumor will have higher amount of vascularity, what happens is on Doppler, you will be able to appreciate a higher vascularity in such a picture, and the resistance to the, because of the dilatation, the resistance is going to decrease, and decreased resistance index of less than 0.40 on Doppler is noted. And simultaneously, if the presence of ascites is noted, there are very high chances that this tumor is going to be a malignant tumor. Okay, so as you can again see in this picture, the capsule thickness, you need to know there is a partial fluid component. Along with that, the partial, there is this cystic areas which are noted. Along with that, the septa is noted. Now again, you can appreciate on this picture that there is a tumor which is noted with the with large amount of the septa, as well as the thickness of the septa is increased, the thickness of the cyst wall is increased, and large amount of the loculi are noted. So all these are helping in diagnosing that, okay, this tumor which we noted on ultrasound, there are high chances that this is going to be malignant. Now, once that is done, you need to go for the further investigation with the CT scan as well as MRI. And both of these are, as we all know, it is going to be expensive, but it helps in a better appreciation of the ascites, assessing how the spread of the metastasis is, and lastly, the lymph node involvement. Okay. So if we talk about the contrast enhanced CT scan, that is going to be better to detect the solid as well as the cystic. So talking about the mass, if you want to understand about the mass, it is going to be better detected with the help of the CECT. Along with that, the omental caking as well as the metastasis to the liver can be better detected with this. Not only that, this CT scan would be helpful for the follow-up. Once the patient has been operated, if the levels of the CA-125 are going to be high, then CT scan can be used for the follow-up reports as well. Now, if you talk about the MRI, then MRI is going to be better helping in picking up the lymph nodes, and as well as the lesions which are going to be more than 1 centimeter. And since this is going to have the high resolution, it will help to detect any kind of spread of the tumor or any mets or enlarged pelvic or the para-aortic lymph node. So that was about this ultrasound, CT scan, and MRI. Now, how are we going to manage such a case further? So once that is, as I mentioned earlier, without surgical staging, this management is going to be incomplete. So you need to go for surgical staging. So what do you exactly mean by surgical staging? Which means you have to take, so once you know that there is some kind of the lesion which is present and likely to be malignant, you go for operative laparotomy, and you explore whole of the abdomen like the peritoneal cavity, remove all the tumors, send it for histopathological examination, and then on the basis of the histopathological picture, you are going to classify this patient that which stage it is, and then you go for the further management. So staging is always going to be surgical. And what do you mean by that? Here we go for the midline laparotomy incision, wherein you perform the hysterectomy, that is you remove whole of the uterus plus both the sides fallopian tube as well as ovaries, which is going to be called as the bilateral salpingo-oophorectomy. And then the treatment is given in the post-operative period based on which classification the patient falls into. The treatment is mainly going to be chemotherapy, wherein you're going to use a combination of the carboplatin with the paclitaxel with the 6 cycles. And if it is an advanced cancer, you can go for the cisplatin and the paclitaxel. So talking about the surgical staging, what exactly you are going to do is that you go for the midline vertical abdominal incision, which is from xiphisternum to pubic symphysis. Then once you open the abdomen, as we know that there is ascites which is going to be present, you just aspirate the ascitic fluid and send for the cytology. If it is not available, you can also go for washing with the normal saline and sending that particular fluid for the cytology. Next, you go for the systematic inspection and palpation of different organs. Okay, so if you talk about the systematic inspection, what you begin with the examination of pelvis, you begin with the uterus, both the tubes, ovary, then Anteriorly, there is bladder. Posteriorly, there is rectum. You inspect the pouch of Douglas, the small intestine, the ileocecal region, ascending colon, the hepatic flexure, transverse colon, and the splenic flexure. Once that is done, you next move on to the descending colon and the sigmoid colon, duodenum, mesentery of the small intestine, and the liver. And lastly, you don't need to forget the liver and gallbladder. And lastly, the undersurface of diaphragm is to be inspected, followed by the assessing of the pelvic as well as the para-aortic lymph nodes. So all these organs, you need to just look for is there any kind of visible growth which is present on such kind of structures. Now, once that is done, what you need to do is you have to again palpate these organs and the surfaces, and any kind of the growth that is present, that is to be sent for the cytopathological examination. Okay. So here the pelvic and the para-aortic lymph nodes, these are performed, they are going to be determining the prognosis of such a case. So that's very important. You go for the random peritoneal biopsy, as well as you have to remove whole of the uterus along with both the sides, fallopian tube and ovary, which is called as the bilateral salpingo-oophorectomy, and the infracolic omentectomy is also to be done. Now, in case of the mucinous tumors, what you need to do is one step further is added, which is appendicectomy is also performed. If there is advanced cancer, so you along with the TAH-BSO, this is also there is what does advanced cancer mean? That is, the tumor has already been to such a size that you might not be able to differentiate the uterus, fallopian tube, and ovary. So you try to go for removing as much amount of the mass as you can see, which is called as the debulking surgery. So in case of the advanced cancer, you need to go for the debulking surgery. So what is that? It is going to be called as cytoreduction as well, where all the visible amount of the tissue is removed. And how will you define that this is going to be optimal cytoreduction? Means you only less than 1.5 centimeter diameter of the tumor nodules, less than that should be left behind, and the survival improves with that of the amount of the lesser the amount of the residual tissue left inside, the better is the survival. Okay, so primary cytoreductive surgery or the debulking is central in the treatment of the advanced diseases, and the residual disease does not include the total volume of the tumor cells behind, but it is rather the diameter of the largest single residual nodule. Now, based on this, you will be removing this particular tissue. You will be sending it to the for the histopathological evaluation. Okay, so on that you will be going for the FIGO staging. So, according to stage 1, which means that the tumor is confined only and only to the ovaries. Okay, so in the stage 1A, the tumor is limited to one ovary capsule is intact, no tumor is on the surface, and the negative for the washing. 1B is going to be the tumor involves both the ovaries, and again the capsule is going to be intact. The tumor is on the surface of, there is no tumor on the surface of ovary, as well as there are negative for the washing. 1C is going to be tumor is limited to one or both the ovaries, that is the second ovary would be involved, wherein C1 includes the surgical spill, that is the intraoperative rupture of the capsule might take place. C2, wherein the capsule rupture before surgery or the tumor on the surface of the ovary. And lastly, we have 1C, where the malignant ascites or the peritoneal washing is going to be positive. Next, we have stage 2, wherein the tumor involves 1A or both ovaries with pelvic extension, which is below the pelvic brim, or the primary peritoneal cancer. 2A includes the tumor spread to the uterus or the fallopian tube, and the 2B includes the spread to the other pelvic organs as well as the pelvic lymph nodes. Next, we have stage 3, wherein the tumor involves one or both the ovaries with the cytologically or the histopathologically confirmed spread to the peritoneum, which is outside the pelvic cavity, or the metastasis to the retroperitoneal lymph nodes, wherein stage 3 is going to be the positive retroperitoneal lymph nodes or microscopic metastasis beyond the pelvis taking place, which means that this tumor is going to be spread outside the pelvic cavity, wherein stage 1, the positive retroperitoneal lymph node only and para-aortic, and stage 3A1 is going to be metastasis of less than 10 mm, and stage 3A2 is going to be metastasis of more than 10 mm. Now, in case of the stage 3A2, we have microscopic extrapelvic above the pelvic brim, peritoneal involvement taking place, which is positive or negative for the retroperitoneal lymph nodes. Stage 3B, which includes the macroscopically extrapelvic peritoneal deposits of less than or 2 centimeters size, with or without the involvement of the retroperitoneal lymph node, includes the extension to the capsule of the liver or the spleen. And lastly, we have stage 3C, wherein the macroscopic extrapelvic or the peritoneal metastatic, which is going to be more than 2 centimeters, with or without the involvement of the retroperitoneal lymph node, includes the extension of the capsule to the liver or the spleen. Lastly, we have the stage 4, wherein the tumor involves one or both of the ovaries with the cytologically or the histologically confirmed spread to the peritoneum, which is going to be outside the pelvis, or the metastasis to the retroperitoneal lymph node, which is taking place. And stage 4A includes the pleural effusion, and stage 4B includes the other structures, including the liver or the spleen. Lastly, we have the inguinal lymph node. Now, in case if the inguinal lymph nodes are involved, then it is going to be always a distant metastasis, which is going to be 4B classification. The CA endometrium, the inguinal lymph nodes will be involved. It is again in case of endometrium, it is going to be 4B. In case of the cancer of cervix, it is going to be 4B. Now, how are you going to manage such a case? So if the low malignant potential tumor, if it is stage 1 as well as grade 1 and 2, you just need to go for the surgical staging. Beyond that, you don't need to treat those women with the chemotherapy. Okay, so if it is a grade 1 or grade 2 tumors with stage 1, just surgical staging is enough. Beyond that, no further treatment, just surveillance is needed. In a young woman who is wishing to preserve her fertility, that is, she wants to preserve a uterus or ovaries, you just have to go for the unilateral salpingo-oophorectomy, and the uterus and the contralateral ovary can be removed once she has the family completed. Next is stage 1A and B with grade 3 and the grades of stage 1C and stage 2. You need to go for surgical staging, followed by 3 to 6 cycles of chemotherapy in the post-operative period, including the carboplatin as well as the paclitaxel. Okay, once it is the advanced ovarian cancer, instead of the surgical staging, what we have here is the cytoreduction, that is removal of as much amount of the tumor we can see, which is also called as debulking surgery. Along with that, 6 cycles of the platinum-based chemotherapy, which includes the cisplatin and the paclitaxel, and each cycle is given after 3 weeks of the surgery. Next we have is the neoadjuvant therapy. So initial treatment with chemotherapy is given, which is followed by the interval debulking surgery, which is indicated particularly in patients who have already a large amount of the tumor, or some kind of medical condition actually is prohibiting from the initial surgery. In patients who have suboptimal debulking is also going to be likely, you can proceed with the neoadjuvant therapy, where you are going to give initially the chemotherapeutic agent so that the tumor size decreases. Later on, you can go for the surgery. Now, how are you going to go for the, once the patient has been operated, how are you going to have post-operative surveillance? That is regular physical examination with the rectovaginal examination and the CA-125 testing. And if any of these are doubtful, you go for again chest X-ray, ultrasound as well as CT scan. This needs to be done. The regular physical examination as well as the measurement of the CA-125 needs to be done every 3 monthly for the initial period of 2 years. Then it is to be done twice yearly for the next 3 years, and later on, once that is completed, every year needs to be done for lifelong. So that was about the epithelial tumor. Now we have other different special tumor which are highly malignant, which includes the dysgerminoma, which ma'am already described about the histopathology of these kind of tumors. So these are going to be the second most malignant tumors, germ cell tumor, and these are going to have the best prognosis, and they are going to be radio sensitive. So the one other thing about dysgerminoma is that it is one of those tumors which is more commonly seen along with the pregnancy. Now it is associated with the dysgenic gonads, which is going to be Y chromosome is present. So any kind of a patient, as ma'am already said, is there any kind of Turner syndrome or Swyer syndrome or testicular feminizing syndrome, any of them you have to go for, or there is a phenotypic female with a karyotypic Y chromosome, there is very high chances of dysgerminoma, and you need to go for the removal of these gonads, because they are at the lifetime risk of development of this dysgerminoma. Thus, phenotypic female with a dysgenic gonads, you have to go for the bilateral gonadectomy. Now, this is already described the picture of dysgerminoma. The tumor marker is going to be placental lactate alkaline phosphatase as well as the lactate dehydrogenase 1 and 2. Now, you're going to, how are you going to manage such a case? So again, since it is a malignant condition, you go for the surgical laparotomy staging, along where you're going to go for removal of uterus, that is total abdominal hysterectomy with the bilateral salpingo-oophorectomy, with the lymphadenectomy and the infracolic omentectomy. Now we all know that this condition is going to be more common in the pregnancy. So if a patient is pregnant and coming to us with a case of dysgerminoma, you have to remove whole of the tumor intact and continue with the pregnancy. If it is in the advanced disease, then continuation of the pregnancy depends on which gestational age of the fetus if it is. Okay, so chemotherapy can be given if it is in the second or the third trimester, because already the organogenesis would be completed in the first trimester. The most common tumor otherwise detected during pregnancy is going to be dermoid, but if it is a malignant tumor which is detected, then it is going to be dysgerminoma. And once that is done, you can go for chemotherapy, which is given would be the bleomycin, etoposide, as well as the cisplatin, which is given every 3 weeks for 3 cycles. Next you have is another malignant condition, which is the Yolk Sac Tumor, which is again, it is called as the endodermal sinus tumor. This is going to be the germ cell tumor with the worst prognosis, and it is seen in very young, small females. Okay, so this is having the worst prognosis. Again, as ma'am already mentioned about the histopathological picture, what you see is the Schiller dual body, and the tumor marker is going to be the alpha fetoprotein as well as the antitrypsin. So how are you going to manage such a case? That is, you go for the surgical staging, you remove the unilateral salpingo-oophorectomy. Since these females are going to be very young, this is more common in the younger age group. The removal of uterus as well as the fallopian tube is not necessary, because it is not going to improve the chances of the survival. Once that is done, you remove the primary tumor. Next, you go for the chemotherapy, that is chemotherapy with BEP, bleomycin, etoposide, as well as cisplatin. Next, we have the sex cord tumors, that is the granulosa cell tumors. Now, there is a peculiarity about these tumors that the presentation of these tumors is going to be relatively early, because the sex cord tumors, they are going to be producing hormones, and these hormones are going to produce the symptoms. So, as a result of which, patient comes to us with at an earlier presentation. So, of the sex cord tumors, the first is going to be granulosa cell tumor. Ma'am already described about the histopathological examination with the presence of these Carcinomas body as well as these crowded cells. And what happens here, there are these are going to resemble the follicle, and these are granulosa cells which are going to secrete the hormones estrogen and androgen. And because of the estrogen, this is going to produce various amount of the symptoms depending upon which age it is going to affect. So if it is affecting, or if the tumor formation takes place after the onset of menopause, what happens is this granulosa cell tumor is going to go and act on the uterus, which is already a menopausal uterus, and produce the postmenopausal bleeding. Okay, if it is in the reproductive age group, it is going to produce the excess amount of bleeding because of the presence of excess amount of the estrogen. Or in the younger, a still younger female, it is going to produce the precocious puberty. So that is about it. About the tumor marker would be inhibin B specifically for this tumor, and you are going to treat such a patient with the removal of uterus as well as the bilateral salpingo-oophorectomy. You can, in case of the advanced disease, you can also go for giving the chemotherapy. Again, it would be BEP protocol. Next is other masculinizing tumor, particularly would be the erinoblastoma, which is going to be called as the Hylas cell tumor or the endroblastoma. The others would be the Sertoli and the Leydig cell tumor. So these are going to produce the androgen. So these androgen go and cause the masculinization into the female, and the patient comes to us with that complaint, or there would be development of hirsutism or virilization, or there will be development of the receding of the hairline, hoarseness of voice, or clitoromegaly. So all these, because of all these symptoms, the patient comes to us at a relatively earlier stage, and we can manage such a condition. Now, to differentiate this, what we have is the serum testosterone level is going to be typically raised more than 200 nanograms per deciliter, and DHEAS, which is going to be the source of this, the dihydroepiandrosterone sulfate, is going to be adrenal. So that is going to be in normal limits. So that was about how the malignant different ovarian tumors are going to present to us and how we are going to manage such a case. Next is the metastatizing tumor of the ovary. So which means that the ovary, the tumor is not going to be primarily to the ovary, it has been metastatized to the ovary. So there are specific terms which is called as the Krukenberg's tumor. So this represents the carcinoma to the stomach, which is metastatized to the ovary, and this denotes to the gastric cancer, which is metastatizing to the ovary. It occurs because of the retrograde spread via the lymphatics. And what you see is the histopathological examination. These tumors are always going to be bilateral. They're going to have smooth surface. There is no tendency of adhesion formation in such tumors. They are going to be freely mobile, unlike that of the other malignant tumors of the ovary, and no infiltration to the capsule. So these are only going to be present on the surface of the tumor of the ovary. They are not going to infiltrate the capsule. Histopathologically, these tumors are going to be the signet ring shape, which is, as you can see in this picture, with a background of the myxomatous stromal, and they retain the shape of the normal ovary. Also, if you're going to go for examination of such a condition, you can note the tumors are going to be waxy in consistency. Now, how are you going to manage such a case? So you have to treat the primary tumor and you have to go for removal of the tumor or the secondaries on the ovary, and this is going to be managed. So the most common cancer which is metastatizing to the ovary in decreasing order would be from the colon, from breast, the gastrointestinal tract, stomach, and the appendiceal tumors. Next, we have the tumor markers, which would be described by Dr. Smriti ma'am. So if we talk about tumor markers,
sorry, I was just about to start my video. Okay, that's not happening. Anyway, I hope you can hear me. So tumor markers. Now, what exactly are tumor markers? Tumor markers are basically chemicals or substances that can be found in your blood, which are being secreted by these tumors. Now, if you know the basic structure or the basic histology or the basic function of these cells, then it's not very difficult to remember why which tumor marker is increased in which kind of tumor. So for example, over here in the epithelial tumors, it's written that CA125 is raised. CA125 is basically cancer antigen 125 or carbohydrate antigen 125. Now, CA125 is a glycoprotein which is found on the epithelium or the epithelial cells. So in epithelial tumors, these proteins would be more expressed, and that is why these will act like a tumor marker of epithelial cells. Similarly, if we come to germ cell tumors, a choriocarcinoma is basically a part of a choriocarcinoma is basically a placental kind of tumor. And we know that generally our placenta produces human chorionic gonadotropin, right? So same way, a choriocarcinoma, the syncytial trophoblast cells of the choriocarcinoma will express HCG, and that is why HCG would be increased in a choriocarcinoma. Now we come to yolk sac tumor. Now, just like a regular yolk sac during embryogenesis or during the fetal life, it produces alpha fetoprotein and alpha-1 antitrypsin. A tumor of the yolk sac would also secrete the same, but in a higher amount. Now, dysgerminoma would secrete LDH and PLAP. And a granulosa cell tumor. Now, if you remember the functional histology of a follicle, you will remember that while the follicle is maturing, at the time of ovulation, when the granulosa cells mature, the granulosa cells start secreting inhibin, so that it gives a negative feedback to the FSH. That FSH should stop now. That is why it's called inhibin. It inhibits the secretion of FSH. So same way, a granulosa cell tumor would be secreting higher amounts of inhibin. Now, having said all of that, tumor markers are basically can be used for any of these purposes. That is, it can be used for screening purpose, it can be used for a diagnosis purpose, it can be used for prognosis purpose, and it can also be used to see recurrence of a tumor after the surgery has been done or after the tumor has been removed. So that is about tumor markers. So I think Dr. Vedi, that's it for today, right?
Yes, that's it.
So I hope this was a very useful session for you, because we tried to integrate pathology as well as obs and gynae in this. And this gave you a better idea of how a patient comes and presents, and then how you find it during the pathological examination, and then how the pathological examination and the staging affects the management. So this was the whole idea of doing an integrated series. So any questions you can put on the chat, and we'll respond to you. And thank you so much. Have a great Sunday.
Thank you, students, for having this session. So have a nice day.